where's the camera? And so what's my voice? I think that's it. That's so tiny. Hi everyone, my name is Amanda from beautifulnursing.com. So I'm here because when I first graduated nursing school, I had no idea where to turn to start studying for my Nclex. I had no idea what they were testing on. I had no idea which program was for me. And so I decided that I wanted to make my own little comprehensive review for you here on YouTube so that it's more accessible to everybody. All right, so we have quite an agenda today. We are gonna go over lab values, ABGs, electrolytes, safety precautions, casts, traction, crutches, canes, walkers, restraints, diabetes, OB, maternity, psych, pediatric, pharmacology, blood therapy, IV fluid types, anaphylaxis, EKGs, delegation, and prioritization. That's it. We're gonna dive right in, and hopefully by the end of this, you'll have a good solid foundation on how you can study and what is gonna be the most important. Remember, the Nclex is a safety test. It's wanting to make sure you are safe as a nurse to practice. So you have to think about that when you're studying. Why would they ask me this question? What would make me safe in practice? Just show them what you showed your clinical instructors and you should be fine, okay? So let's start. Hi guys, so I know lab values are quite a struggle for many people, so watch these 2 TikToks that I made on lab values to see if they help clarify these values for you, and then we're going to talk about what to look for. Well, I'm getting another call. Student nursing fairy godmother speaking. Lab values, of course, I can help with that. Potassium, the number of bananas you buy from a store, 3.5 to 5. Fluoride, it usually has to be at least 95 to 105 degrees to go swimming in a pool. Hemoglobin, think puberty. Males, 13 to 18. Females, 12 to 16. Females usually go through puberty first. Magnesium, think of magnum. Okay, these are for men that are at least 1.5 to 2.5 times bigger. Finally, bun levels. If somebody has a nice bun, usually they're a perfect 10 to 20. Student nursing fairy godmother speaking. More lab values, of course I can help. Calcium. You're reporting a theft from a red-headed mermaid? Calcium. Call 911. 9 to 11. Phosphate fossils. Oh my god, these are at least 2.5 to 4.5 million years old. Creatine. He is a creatine creature. On a scale of 0 to 10, he's definitely a 0.5 to 1.5. White blood cells. Kids ages 4 to 11 are always getting sick. Achoo! Really? Sodium. This is absolutely delightful. This can of cola only cost me $1.35 to $1.45. $1.35 to $1.45. So now that you know these lab values, you have to figure out what is critical, what is concerning to the nurse. Now, if you have a person that's in with like pneumonia and maybe they have a white blood cell count of like 13,000, that's going to be more normal. We're looking for things that are abnormal for their diagnosis coming in, and there are some labs that are critical no matter what it is. I want you just to remember the number 6. When you think of 6, I want you to think of critical, the concerning labs. If the pH is in the 6s, if potassium is in the 6s, so 3.5 to 5 is normal. If it's over that, so over 6, that is going to be concerning, and they might having heart arrhythmias. So CO2 of greater than 60 is concerning, and O2 of less than 60. And platelets, this is the only one that doesn't follow the 6s, but if it's less than 40,000. All right, so another thing with labs I wanted to mention was something called neutropenic precautions. And what that means is if a patient has a white blood cell count of less than 1,000 or neutrophils of less than 500, that means that they are put on what's called neutropenic precautions. So any person that is taking care of that patient needs to have strict hand hygiene. They need to not have fresh fruit or fresh vegetables or fresh flowers in the room. They limit the amount of visitors that come in. They cannot have people that have certain illnesses come in that room. So again, that's if a patient has less than 1,000 with their white blood cell count or less than 500 with their neutrophils. All right, so you might get an ABG question. ABGs are arterial blood gases. They're to look at the blood to see the oxygenation, to see if they're in an acidic state, alkaline state. So you need to know the numbers with the ABGs. The first thing you should know is HCO3, which is bicarbonate, so it's basic. So that number is going to be 22 to 26. You should know PaCO2. That is going to be your carbon dioxide, and those numbers should be 35 to 45. And then you should have your pH, which is 7.35 to 7.45. Now, if you can remember the pH, you can remember the PaCO2 because the last numbers in the pH, 7.35 to 7.45, 35 to 45. That's what the PaCO2 is. So you might get one of these questions and we can do one together. So when you see that the pH is high, usually that patient is going to be irritable. Everything in your body goes up. They're going to be very irritated. Their respiratory rate's going to be high, BP high, heart rate is high. So everything is kind of going up. Whereas if the pH is low, like if they're in an acidotic state, that is more critical. That's showing us that their body is shutting down. So I'm just going to tell you what causes the body to be in an alkalosis state, or meaning that the pH is high, or they could have high bicarbonate basic, remember, bicarb basic. Remember, a patient is put in an alkaline state if they have excessive vomiting, suction, or hyperventilation. Okay, so if you remember those three things, then everything else you can kind of put in that category of metabolic acidosis or respiratory acidosis, okay? Those three things are going to cause that alkalosis. So with acidosis, meaning your pH is going to be low, but your PaCO2, which is your carbon dioxide, is going to be high. So a very common cause of that is excessive diarrhea. Diarrhea is basic. Your stomach, the acid in your stomach, that's acidic. But your diarrhea, your bowel movements are basic. So if you're getting rid of a lot of that basic material, your body is going to be acidotic. So signs and symptoms when your body is in acidosis or shutting down is going to be bradycardia, lethargy, hypotension, coma, and those are some of the symptoms. Again, it's just showing when your body's in an acidotic state, it is shutting down, it's not functioning correctly, and we need to, intervene. Normally with the Nclex, that, the questions might be like, you have a patient coming in with excessive diarrhea, what metabolic state might they be in? But if you don't get a question like that and you actually have to do an ABG question, let's do it together. So you get a whiteboard and you want to write these down, okay? So let's get a pretend question. pH is 7.5. That is going to be high, so it's acidotic. PaCO2. PaCO2 is normal. And then HCO3, normal is 22 to 26. This is low, meaning that it's acidotic. So it looks like here when we combine our arrows, we figure out, because this, remember, this carbon dioxide is respiratory. This is going to be metabolic, this bicarbonate. So we have metabolic acidosis because they're acid. So metabolic acidosis. All right, so as I said that the Nclex is a safety exam, so knowing your proper PPE and your safety precautions is crucial. So we're gonna start out with going through each of the precautions. So we have standard precautions, which you should know, but I will just repeat it. Hand hygiene, gloves, gown, mask. When we say standard, this means that applies to every single person that walks through the door in a clinic, hospital, whatever, okay? So next we have droplet. Droplet, think of water. They're droplets in the air, okay? So this is what you see in pertussis, pneumonia, influenza, rubella, and mumps, okay? So with this one, you want to always have standard precautions, but you also want to be wearing a surgical mask and have a private room if available. Now, if there isn't a private room, and in the question they say, okay, you have a patient that is on droplet precautions and you need to, put two patients together, you want to find somebody else that has that same precaution as your patient. So like putting two pneumonia cases together or pertussis and pneumonia, you don't want to put somebody that's on, airborne precautions with someone on droplets. So making sure to know those differences is very important. So the next one, airborne, this is going to be measles, TB, and varicella chickenpox. And so with airborne, again, we have those standard that are always in place, but on top of that, you want to have an N95 mask, and you want to have the patient in a negative pressure room, okay? And then you also want to have a private room if available. Again, you can put together two people with airborne precautions, but a private room is preferred. And these are for patients that have measles, TB, or varicella. So now finally, contact. This one, a lot of people, when they hear it, they're like, C. diff. That's always the first one, at least that I think of. But with contact, this can also apply to MRSA, VRE, herpes. And it's important with contact that you use very good hand hygiene. That is the number one thing that you should be doing to prevent cross-contamination or infection. And then gloves, gown. All right, so the next thing you should know is PPE, how to put it on and how to take it off. Now, thankfully, with taking it off, there's a really easy way to remember this, and it's just to do it alphabetically. So the components of PPE are that gown, gloves, mask, goggles, but with taking it off, it's alphabetical. So we're gonna start with gloves, right? Because GL is the first one. And then you're gonna have your goggles, G-O-G, and then gown, G-O-W, and then mask. So it's alphabetical. So for putting PPE on, I always thought of this about Big Don putting on his big equipment. So he always wants to put the big things on first. So he puts his gown on, and then his mask, and then his goggles, and then the gloves. So Big Don wants to put on the big equipment first. All right, so I did have an Electrolytes video TikTok that was quite a great hack that you guys should watch now. After watching that video, remember that when you have a patient that has a potassium in the 6s, that can be critical. So that's one of those big electrolytes that you need to look for. Also, you should know that with potassium, you never want to do IV push with potassium. And if you do have a patient that has high potassium levels, you want to give them the antidote, which is K-exalate. so sodium K-oxalate. A few other things with electrolytes. When you think of calcium, you think of skeletal muscle, calcium movement, So something with when you have low calcium, your skeletal movements are going to be abnormal. So you're going to see a person have tetany, right? Abnormal skeletal movements. They could have Chvostek's sign or Trousseau's sign. All right, guys, so now that we've done a lot of these lab values and electrolytes, we're gonna go on to crutches and canes and walkers. And I promise this section is gonna be a lot easier than you think. All right, so with crutches, your fingers should be 2 finger breadths below the axilla. So the crutches should come up to 2 finger breadths below the axilla line. Okay, so as far as the crutch gaits, so pretty much when you hear 2 or 3 or 4 point gaits, that just means the amount of points that are on the floor when this person is ambulating. For an example, like a 2 point gait, that just means that you're moving, like let's say your left crutch and your right foot together. You're moving those two together. Now you're usually gonna, with crutches, move your affected side or your weak side first. But with 2 point gait, think about it. You have 2 points on the ground. You're gonna move these 2 points together. So maybe the left crutch and the right foot, or the right crutch and the left foot. So then for the 3 point gait, you're gonna move both your crutches forward and have your weak leg advance and your strong leg on the ground move forward. So that's gonna be 3 points on the ground. The 4 point gait, it most resembles walking, right? Because 4 points. You're gonna have each of those crutches on the ground. You're gonna have each of your feet on the ground. So you're gonna have, maybe you usually, again, move your affected side first, but you could move your left crutch gait forward and your right leg forward, then your right crutch gait forward, and then your left leg forward, if that makes sense. So again, when you think of crutch gaits, it's just the amount of points that you have on the floor. Okay, and then for swing through, it's just what it sounds like, a swing. So you put both crutches forward and your body kind of swings through ahead. This is for people that have, stronger extremities. All right, so I have a kind of a goofy way to remember stairs with assistive devices. So when you go up the stairs, you want to use your good leg or good foot first. When you go down the stairs, you want to use your weak or bad leg or foot first. So I always remember that with like, good, you're going up to heaven, or down, it's bad, you're going somewhere else. That's how I remember going upstairs. The stairs up to heaven is good. You're using that good leg first, whereas down, there's different plans. All right, restraints. So a restraint is a good thing to use if a patient becomes aggressive. Now, you do not want to use restraints on somebody that may have a past history of being aggressive or a past history of something. You want to use it only if in that present moment that person is going to harm themselves or somebody else. Or if somebody, maybe with dementia is pulling on their tubes, you might have to put them in a restraint. So for restraints, if they're less than 9 years old, it can be in for up to an hour. 9 to 17, 2 hours, and adults for 18 plus, 17 plus is 4 hours. So an easy way to remember that is you keep timesing it by 2. So less than 9 is 1, and then the next one is 2, and then 2 times 2 is 4. So if you keep timesing that by 2, that is the number you're gonna have of how many hours that patient should be in a restraint. So there are 2 different types of restraints. There is chemical, which is giving some kind of medications, maybe psychotropic or something that will calm the patient down and maybe sedate them. Otherwise, there is mechanical restraints, which is going to be, some kind of Velcro or ties that will keep the patient held down. Informed consent is needed for restraints. You also need a MD order, but in an emergency, you can apply restraints. You just need to make sure you have that order within an hour of applying those restraints. So with medication administration, the basics you should know is that with IV, it usually has an onset of 5 to 15 minutes. So it's the quickest way to get medication in and working. Sub-Q and IM can take longer. Usually they're 35 to 45 minutes for an onset. Ear antibiotics or doing some kind of ointment, you want to make sure if the patient is 3 years old or older, 3 years plus, that you pull the pinna up and back, okay? So when you're doing some kind of ointment administration and the patient is older than 3 years old, you want to pull the pinna up and back. And I always think of that because when people are older, you have to kind of look up to them. So that's how I remember that. And the Nclex is a safety test. So know your rights in medication administration. So I always like to remember with this little phrase, my parents drove right to Dairy Queen. All right, guys, so when you go into this Nclex exam, there's a good chance that you might get a question on diabetes. So it's important to know the different types and the different types of insulin that you might use to treat it. So let's just go over it really quickly. So type 1, I always remember with the letter K, okay? So type 1, you want to keep insulin nearby. These patients are insulin dependent. They need insulin to live. Another K, kids. Usually this is adolescents that have this onset of finding out that they have diabetes type 1. Okay, these are younger patients that have this diagnosis when they find out. And so that's another K. And then the last one for type 1 is ketosis, ketosis. In type 1, you have the DKA, diabetic ketoacidosis, which we'll get into. But if you can just remember the letter K with type 1s, you will be great. So the symptoms, you see polyuria, which is excessive urination, polyphagia, which is excessive appetite, and polydipsia, which is excessive thirst. So those are the 3 big telltale signs of diabetes. And so with the treatment in type 1, again, I said if they don't have insulin, they will die. So remember DIE, D for diet, I for insulin, that is the most important thing that they need, and E is exercise. Exercise is like a natural insulin, so those 3 things are very important for our type 1 diabetics. Type 2 is opposite. Usually these are people who have an adult onset because maybe they weren't following an exercise regime or a certain nutritious diet, obesity and being overweight. So they can develop type 2 diabetes. It's an adult onset. They don't have ketosis. The symptoms are very similar to type 1, but the treatment is going to be diet. Again, that's the biggest thing with type 2. You want to make sure they stay away from those carbs and that they are having a more nutritious diet with less carbs and calories and protein. They want more protein. They're going to have oral hypoglycemics, so that's going to be your metformins. And then A for activity, so physical activity, 5 times a week, 30 minutes. That is usually what is recommended. And yeah. All right, so diabetes insipidus. What is that? It's a decreased ADH or antidiuretic hormone. So what that is think of diuretics. They're getting rid of fluid in the body, right? So if you have antidiuretics, that fluid is staying in the body, but you're having this excessive urination, this excessive thirst, so that polyuria and polydipsia, and you're going to be really dehydrated. So I always remember this diabetes insipidus with sip, the word sip in there. I need a sip of this because I'm dehydrated. Diabetes insipidus, I need a sip of this because I'm very dehydrated because I'm having so much urine output and I'm very thirsty. So it's not uncommon to get a urine specific gravity question with diabetes because with certain like diabetes mellitus and diabetes insipidus, you have a high amount of urine output, right? So you're getting rid of a lot of urine. And what does that do to your urine specific gravity? It increases. It's completely opposite. And so that means that your specific gravity, it's more concentrated because if you're having less urine out, your specific gravity is going to go high. If you're having more urine out, your specific gravity is going to go low. So normal urine specific gravity numbers are 1.003 to 1.030. All right, so complications of diabetes. So DKA, diabetic ketoacidosis, that comes with type 1 diabetics. And you can remember this by them having a blood glucose of usually over 250. And there is a simple way to remember the signs and symptoms of DKA with just remembering the words DKA. So D is for dehydration, K is for ketones, okay, because you're going to see ketones. You're also going to see Kussmaul breathing, which is another K. And you could see high potassium, which is another K. So D, dehydration, K for ketones, Kussmaul breathing, and high potassium. And then A, meaning they are going to be in an acidotic state. They're going to have acetone breath, that fruity breath. And they might have anorexia, so they might not be eating due to them being nauseous. So what is the treatment for DKA? The biggest thing you want to give is those IV fluids with regular insulin. Hypoglycemia. This actually can be a fatal, life-threatening complication of diabetes when your blood glucose is less than 70. So usually the causes are by a patient not having enough food or too much exercise or too much insulin, and their blood glucose is just tanking. So usually they're going to look like they're almost like drunk. They're going to have slurred speech. They might have a delayed reaction. Their heart rate and respiratory rate can be high. Their BP can be low. So it looks too kind of like they're in shock. So they're going to have those symptoms. And with treatment, if they are coherent and they're able to swallow, you want to give orange juice first. That's the first thing that you're going to do, is give some kind of like rapid carbs or sugar, like orange juice. And if you can't do that, then you're going to have to give them glucagon, which is going to raise their blood glucose levels. Okay, and then finally HHS. Or HHNK, which happens in our type 2 diabetics. Usually you'll see blood glucose levels of over 600, and with these symptoms, you're going to see that they're going to have hot, flushed skin, and it could be caused from like dehydration. Again, when you have dehydration, your skin is going to be hot and flushed. And so the treatment for that one is just rehydrating the patient and giving them those fluids that they need, along with insulin. All right, so you're gonna have to know insulin timings and the different types. So we're gonna just start. So with rapid, you're gonna have aspart or lispro. They all have R's in it for rapid. These are ones that are quick. So their onset is gonna be 15 minutes. Their peak is gonna be 30 minutes, and their duration is gonna be 3 hours. 1533. This is for rapid lispro or aspart. The next one is short-acting insulin. This is the one that's rapid too, that you can run IV. So this is going to be your regular insulin that is short-acting. This one is the only one that can be run IV, and your onset is going to be 1 hour. Your peak is going to be 2 hours. And your duration is 4 hours. So again, you can just times it by 2. So 1 times 2 is 2, and then 2 times 2 is 4. So that makes it a little easier to remember that one. All right, so the next one is intermediate acting, NPH. So not clear, it's not fast. And that one is, you know, that cloudy one, as I said, not clear. So the onset with that one is going to be 6 hours, the peak is 8 hours, and the duration is 12. So 6, 8, 12 for intermediate. Finally, the last one, which is long-acting Lantus. This one is going to not even have a peak because it's going to have a 24-hour duration. Usually this patient takes it once a day. The duration can actually be anywhere from 12 to 24 hours, and you can give this medication in the night. But just remember, long Lantus. It can also be glargine. So those are the ones for long-acting insulin. Just a few more things with diabetes. Remember, normal blood glucoses are usually 70 to 110. When a patient is in the hospital, we want to aim for them to be around 140 to 180. Some other things to think about is an A1C. What that is also looking at your blood glucose levels, but this is not the kind of thing you can fast for overnight. It looks at the body's levels for the last 3 months. So you just have to remind that patient that's getting an A1C test that they do not need to fast for it. And usually you want to have less than 6 is considered normal. If they already do have diabetes, you want to have them less than 8. Honey, we're pregnant. When am I due? Okay, so it's last menstrual period minus 3 months plus a week. Okay. Oh, yeah, these contractions. Yeah, I'm 30 weeks. Okay, I'll head on in. Thank you. Probable signs of pregnancy that a woman might notice is Goodell's sign, which is softening of the cervix, or they might see Chadwick's sign. Chadwick C, cyanosis C. So you'll see that cyanosis in Chadwick's sign. All right, so I'm sure you heard all about the fundus back in Ob-Maternity, but overall the fundus is the top of the uterus. It keeps changing position as the woman progresses in her pregnancy. So there are some important times to know. So at 12 weeks is when they usually can start to palpate the fundus. And then at 22 weeks, the fundus should be at the umbilical. After 24 weeks, the fundus should be the same height as the number of weeks that the woman is in her pregnancy. At 16 to 20 weeks, a woman should feel quickening, which is just a fancy term for the fetus kicking. So it is common in the first trimester of pregnancy for the client to have a lot of nausea. That is why you want to tell them to have dry carbohydrates, so like crackers, before they get out of bed. Now, a pregnant woman should not be taking ibuprofen. That is a category X. They can take acetaminophen. All right, so you should know the stages of labor. So in stage 1, that is when the cervix is dilating from 0 to 10 centimeters. And there are 3 phases in stage 1. And the first phase is latent, when the cervix is dilated 1 to 4 centimeters and the patient's contractions are not very close together, okay? So they're gonna be like 5 to 30 minutes apart. They can be in this phase for weeks. Phase 2 is when it starts to get a little bit more serious. It's active. So this I like to think of when it's active, it's happening kind of 24/7. So that's when they're gonna be dilated 4 to 7 centimeters. Get it? 24/7, 4 to 7 centimeters. And their contractions could start to be 3 to 5 minutes apart. Last phase is the transition phase, when the client is going to be 8 to 10 centimeters dilated. Usually they're like 100% effaced, and their contractions are 2 to 3 minutes apart. So contractions that last longer than 90 seconds or closer than 2 minutes apart are a very bad sign. That is a danger sign that's saying, okay, this fetus could be in trouble. They could have fetal hypoxia. So we want to, do something right away. You need to intervene when you see that these contractions are longer than 90 seconds or less than 2 minutes apart. Great, so here are some common OB and maternity meds that you should know. So if a client comes in and she is preterm and having contractions, we might try to slow down those contractions by giving her a tocolytic Terbutaline. I think of a turbulence on a plane. We want to slow that plane down, slow those contractions down, and that's what terbutaline is. Now, on the other hand, if maybe a woman is past her due date, she's maybe at 41 or 42 weeks, whatever it is, or we need to get the baby out, we're going to give that woman Pitocin or oxytocin. This is going to induce labor, but this can also be used for postpartum hemorrhage. So that is an important drug that you should know is Pitocin or oxytocin. All right, so complications of pregnancy. The first one is placenta previa. That is that painless, bright red vaginal bleeding that the patient has because their placenta attached to part of the uterus instead of the fundus, and it causes this bright red, painless bleeding. So you're gonna wanna give them fluids, blood, and they might have to deliver their baby. All right, so the next complication is abruptio placentae, which is exactly what it sounds like. The placenta was separated from the uterus, so you're going to see this dark vaginal bleeding. It's going to be very painful. So with that one, you're going to want to do oxygen, you want to have bed rests, they're going to have to deliver. Another complication that you should be aware of with pregnancy is going to be preeclampsia or eclampsia. So what that is, if you remember pre in preeclampsia, that stands for proteinuria. So these clients are going to see protein in their urine. They're going to have a rising blood pressure, a high blood pressure, and they're going to see edema. But the difference between preeclampsia and eclampsia is that the client with eclampsia is going to have seizures. So if they come in, you're going to have to put them on seizure precautions. Okay, and just remember with seizure precautions, what we want to do is we want to lie them on their side. We don't want to have anything in their mouth like a tongue blade or anything. You don't want anything in the mouth. You want to make sure that you have oxygen and suction at the bedside. You also want to have them in a secure position. So if they are up in bed, you want to have the rails up. If they're down on the floor, you want to be with them. You want to time the seizure and, just watch. And yeah, you might have to give them some kind of anti-seizure medication. For most complications in OB and maternity, if you are in a rut and you don't remember anything, just remember this, that you want to use the phrase lion. When you hear or see you have a question about OB, maternity, and some kind of complication, remember this. L is for lie them on their side. I is to increase IV fluids. O is to give them oxygen, and N is to notify the provider of what's going on so we can intervene as quickly as possible. All right, so fetal heart rate is 110 to 160. If you see fetal bradycardia, if their heart rate is less than 100, you're going to stop Pitocin and do lion. So lie on the left side, the increase IV fluids, oxygen, and notify the provider. Now, there are different fetal heart rates that you should be aware of because you might get a picture of it, you might get a question, and we're gonna go over it. So with fetal heart rates, just remember that phrase veal chop. So V for variable, which is very bad. So VV, variable, very bad. Just remember that is a more fatal situation. You have to intervene quickly because that is due to cord compression. The next one is early acceleration. So that is going to be head compression. That is okay. And the next one is accelerations, which again is okay. Then the last one is late. This one is not good. So this is uteroplacental insufficiency, and with that, you are going to use Lion. When a woman is in recovery after giving birth, there are 4 things that you should be checking frequently. One is vital signs. You want to make sure you're looking if there's any signs of, infection or complications that you should be aware of. 2 is checking the fundus. So with that, if you hear the words that it is displaced, you want to catheterize. If you hear that it's boggy, you want to massage the fundus. You want to be checking those perineal pads. If they're saturated in less than 15 minutes, that might be something that you have to intervene with. And they might, need to have Pitocin or something if they're having a postpartum hemorrhage. And then finally repositioning and check for bleeding. The postpartum to the fundal height should be after 24 hours back at the umbilicus. All right, so fetal positioning. This is something you should also know is the most common fetal positions that are most wanted because they have the least risk of complications are LOA and ROA. So left occiput anterior or right occiput anterior. The most dangerous fetal position that the baby could be in is OP, which is occiput, I can't pronounce it right, posterior. So with that, you're going to put the patient in knee to chest position and have them push. So the fetal station is the fetus's presenting part in relation to the maternal ischial spine. So you'll see it anywhere from like -5 to +5. Been in labor for a while and they're still at -1, meaning that they're not descending down the uterus, then that could mean that maybe the head is too big or there might be some other issue at stake. But if the fetus is in like a +1 or +2 station, that means that they are going down. That means that they're doing well. That means they're ready. Psychiatric disorders, the big ones that you should know, there's major depression, which is, somebody having many different symptoms like sadness, lethargy, fatigue, weight gain, weight loss, plus anhedonia, which is that loss of pleasure in doing things they normally would or in doing everyday things. Schizophrenia, having these hallucinations, these delusions they might have, and then bipolar. So bipolar, you're going to have 2 different types. Bipolar 1 is more severe. This is going to be more of that mania. So when somebody is really hyper, they're talking really fast, they're moving fast, they might wear bright colors and walk into the street and think they're invincible, that they can't be hit by cars or something like that. So that is the mania part of bipolar. Whereas the other part of bipolar has the depression. So there's kind of a mix of the 2, and that's what makes it bipolar, is that mania and the depression. In bipolar 2, it's a less severe form that's more emphasized on the depression part of bipolar. There are some things that you need to do as a professional nurse to have a therapeutic communication and relationship with these patients. So one is that you're going to acknowledge their feelings. Say, I see that you are feeling this way. How does this make you feel? Or, tell me more about how you are feeling. That's always the most sweet spot phrase. Tell me more. Tell me how you feel. So if there is an answer for that, pick that one, because usually it's that. So again, you want to acknowledge their feelings. You want to put them back in reality, present reality. So, say, I know that you're seeing this, or I know you're hearing these sounds, but they're not real, they're not here. I'm here, I'm real. Kind of bring them back to reality. They kept talking about something that, you weren't comfortable with, other residents maybe weren't comfortable with. You're going to say, hey, that topic is off limits, or, I'm sorry, but we can't talk about that anymore. Dementia is usually the first stage of Alzheimer's. Alzheimer's is that more severe memory depletion that you need to make sure to keep assessing their alert and orientation, presenting reality. And if they don't have dementia, if all of a sudden they have this onset confusion, they might have what's called delirium, which is like this temporary temporary psychosis that usually can come from, you know, having a UTI or high fevers. And assess if they're, you know, they're alert and oriented, and make sure to reestablish, you know, you're in a safe place and this is not going to last, because with those patients that have delirium, that is a temporary thing, and you need to keep reminding them of that in a therapeutic way. All right, so we're going to get into pediatrics with talking about tetralogy of Fallot. So what is that? That is a heart defect that causes chronic hypoxemia. And so it's like they're not moving at warp speed. Get it? Like their heart's not pumping well enough to get oxygen out into the body. So I remember the word VORP. So I'm going to tell you what that stands for. It is V for ventricular septal deviation, O for overriding aorta, R for right ventricular hypertrophy, and P for pulmonary outflow tract obstruction. Is one heart defect that you should know with pediatrics, but all of these other pediatric heart defects, it is coincidental that all the ones that start with a T are the ones that are considered trouble or more complex cases that need further interventions or instructions. So an issue that some infants can face is this bilirubin, this excess bilirubin that causes what's called jaundice or yellowing of the skin. Now, normal bilirubin levels are 10 to 20. And so if jaundice is in the skin, there's something called kernicterus, which is bilirubin in the brain. And that can cause this opus stonos, which is this like positions of babies being hyper extended. So that's just a side complication of having bilirubin in the brain. So on to the more common pediatric milestones that you should know is at 1 month, they should have a grasp reflex. So when my daughter was born, she grabbed my finger right away. That was amazing. And that's what they should have. By 4 months, they should be rolling from front to back, and they might be starting to smile, which is so cute. And then around 6 months, they should be rolling from back to front. This is when they also can be starting their first sounds, and they start getting teeth. You'll start to see baby teeth starting to erupt around 6 months. Now, 6 months is also the period where if the baby is on formula or breastfed, they can supplement with milk or other foods that are mashed. So like avocados or bananas or any kind of like soft food. So that's when you can start introducing those foods, is at 6 months. So then at 8 months, they should be able to sit unsupported. 9 to 12 months is when kids can start to walk. To go on at 2 years, they should be able to kick or throw a ball, walk up and down the stairs. So by 3 years old, they should be able to run or draw a circle. And then 4 years old, you know, they'll start to use scissors or pour beverages. These pediatric milestones, you want to keep in mind that, you know, if you get a question that asks, what should a 6 month be able to do? And it gives you this list. Make sure to do the one that is like one that you would see at 2 months or 3 months, something that you know they should be able to do at that age, because not all kids that are at 6 months start to get teeth, or not all kids that, you know, are 9 months old start walking. You know, some kids, it takes a lot longer. So make sure to pick the earlier month or milestone than what they're actually asking, if they're asking like which one should they know how to do. So just a note that back is best, so lying a baby supine is best when they're infants, to prevent SIDS and also suffocation. And another thing is that for pain levels, you can tell a child's pain level by either using the Wong-Baker FACES scale, which can be used from 3+, or the FLAC scale. This one is usually used for 2-month-old to 7 years old. Also important to know, if you get a pediatric question, is about nutrition. Now, when kids are in the school age, so 4 to 6 years old, they might not start eating as much, and it's because they're growing at a slower pace. So they develop something called physiologic anorexia, which is where they just don't have that need to eat. So I remember in my case with my daughter, our pediatrician said, you know, she's getting, you know, 1 full meal a day. Like, that was good enough for her, because, you know, she's not demanding as much. So it felt like she was never hungry, but that can be normal. 2, in the form of nutrition, you want to make sure that half their plate is going to be fruits and veggies, 1/4 of the plate is grains, 1/4 is protein, and 1 cup dairy. All right, and then for medication administration for pediatrics, remember that it's different, that their dosages are usually based on weight. So if you get a dosage calc question, make sure to pay attention if is a pediatric client, that you look at their weight and what is appropriate for them based on that. So the Nclex is a safety exam. So with pharmacology, you should know toxic drug levels. So we're going to start with lithium. Lithium is used for bipolar disorder, and those levels are 0.6 to 1.2. It is toxic over 2. The next one is digoxin, otherwise known as digitalis, otherwise known as lanoxone. It is used for AFib, atrial fibrillation, or heart failure. Those levels are 0.5 to 2. Anything over 2 are toxic. The next one is theophylline. Those relax airway spasms. Those levels are 10 to 20. Anything over 20 is toxic. And then the last one is phenytoin or Dilantin. Those are an anti-seizure medication. Those levels are, again, 10 to 20. It's toxic over 20. Here's a quick little TikTok video on antihypertensive medications that you might need to know. It's such a beautiful day in nature. My blood pressure is so low. That pine tree is blocking my calcium. Come on. Oh, our beta fish is so funny. LOL. It's almost like he slows our heart rate just being by him. Ace, you need to take a chill Pril to relax your blood pressure. I am Jafar, Sultan of Agrabah, because I have decreased the workload of my heart. I am the Sartan. The tide of this pool is making me swim so hard that it's literally draining the fluid from my body to lower my blood pressure. Oh, diuretics. And here is another TikTok video on psychiatric medications that you should know. So again, with psychiatric medications, you just want to remember your A, B, C, D, E's, F, G's. So A, anticholinergics, B, blurred vision, C, constipation, D, drowsiness, E, euphoria, F, photophobia, G, granulocytosis, or low white blood cell. And phenothiazine is a first-generation typical antipsychotic, also an antiemetic, and it's a major tranquilizer. Tricyclic antidepressants. I always think of this one because, you know, when you're on a tricycle, you're releasing these endorphins and they're elevating your mood. So one of the common drugs is Elavil. So Elavil, Aventil, Desiril, anything ill that'll end with, and they're mood elevators for depression. Benzodiazepine, so these are your PAMs, and diazepam, all those PAMs. And they're used pre-operatively, they're used for muscle relaxants, they're used for alcohol withdrawal. And then for MAOIs, usually they'll start with that MAR, NAR, or PAR. The big thing to know with MAOIs, they are a antidepressant, but they are not as commonly used because they can have a lot of interactions. But it is important to know that it can cause hypertensive crisis if combined with foods that are high in tyramine. So you want to avoid like smoked meats and cheeses, avocados, bananas. Lithium, again, is used for bipolar disorder. So just remember the P's with lithium: peeing, pooping, and paresthesia. Those are the 3 P's of lithium that you should know. And when lithium is at toxic levels, like I said, levels for lithium are 0.6 to 1.2. Anything over 2 is toxic. When they have toxic levels, they can have the T's: tremors, a taste that's metallic, and too much pooping, so diarrhea. So tremors, a taste that's metallic, and too much pooping, so diarrhea. Those are the toxicity symptoms. And so, another thing with lithium to know is that you need to watch also their sodium levels, because patients can get low on sodium and they might need increased sodium to have normal levels if they're on lithium. Prozac, Zoloft, those are all SSRIs. Prozac in particular, that can cause insomnia, so you don't want to have that at night. But these ones, are antidepressants. They can have anti-anxiety properties. So with SSRIs, there's something that can be caused if there's too much, called serotonin syndrome. And a way to remember that is with the acronym SAD. So S is going to be for sweating, A is for apprehension, and D is for dizziness. And they might even have a headache too. So it's kind of those serotonin syndrome kind of looks a lot like panic and anxiety. They're having too much serotonin, so they're going to be sweating, apprehensive. They're going to be having that dizziness and might have a headache. So that's a way to remember serotonin syndrome with some of these SSRIs like Prozac or Zoloft, sertraline. So 2 medications that you should be aware of too is, just your ibuprofen and acetaminophen. So both of them are antipyretics, so anti-fever, analgesics, anti-pain, but ibuprofen is also an anti-inflammatory. And aspirin, which is part of that ibuprofen family, is also an antiplatelet. Clopidogrel is an antiplatelet used to prevent MI and CVA, but there are those side effects because it is an antiplatelet. They have a higher risk of bleeding and hemorrhage, so you have to watch for that. Also know warfarin versus heparin. So warfarin is like a maintenance oral anticoagulant. Make sure to measure the PT-INR. The INR should be 0.8 to 1.1. Less than 1.2 is good. And heparin is like an immediate onset through IV or sub-Q that can be used as an anticoagulant that you might see in the hospital. And you want to check the APTT levels. Great, so some cardiac drugs you should know is nitroglycerin. Nitroglycerin is a vasodilator that decreases your blood pressure. It dilates the vessels. It is used for patients that are having stable angina, so they can take those 3 times 5 minutes apart. Now, if they're not having any relief from taking the nitroglycerin, they need to call 911 because they're probably having an MI. Important thing with nitroglycerin too is you cannot mix nitroglycerin with erectile dysfunction medications like Viagra. with digoxin. I already talked about digoxin, but it's a cardiac glycoside used for heart failure to help with those contractions of the heart. You just want to remember those levels again, so that 0.5 to 2. Epinephrine, this is a vasopressor used for sepsis, shock, asthma. It'll help increase that heart rate, that cardiac output, and blood pressure. Okay, so here are some respiratory drugs that you should know. First is albuterol. This is a short-acting, rapid beta-2 agonist, usually used for acute asthma attacks. Then there's theophylline, which is a bronchodilator. That's more of like a maintenance medication, but you want to remember that those levels should be 10 to 20. So then you want to remember prednisone. That is an anti-inflammatory medication, but you never want to abruptly discontinue using it. I wanted to talk too about antimicrobial drugs. So anything with psyllin, like amoxicillin or penicillin, these are broad spectrum antibiotics that can be used for various infections. Do not want to give a patient cephalosporin if they are allergic to penicillin. It's very important. That is a huge safety issue if you give a patient who is already allergic to penicillin cephalosporin, because they have the same properties, some of the same properties. One antibiotic you should pay attention to is aminoglycosides. Somebody called it a mean old myosin. So it is the top gun. It's these big bad antibiotics that we're going to use on these nasty gram-negative infections, trying to wipe them out. So with that, when you think of a mean old mice, think of a mouse. Mice have these big ears, right? So just remember there's ototoxicity. And if there's issues with the ears, then they're going to be dizzy, and they might have some other issues like vertigo. And then it also causes nephrotoxicity. Rifampin, this is a medication used for TB, but the big adverse effect to remember is that it can turn your body fluids orange. So you might have orange tears, orange sweating, orange urine. That can be a common side effect. And you should know the number one way to check for nephrotoxicity is check the creatinine levels. Always check creatinine levels for nephrotoxicity. Other antibiotic to be aware of is vancomycin, and this can cause red man syndrome and hypotension, which is something you need to monitor for. Other drugs you want to know is statins. This is an anti-hyperlipidemic drug, so you want to know that cholesterol should be less than 200, triglycerides less than 150. You want your LDLs, which is your lower density lipoproteins. That should be less than 100. The low are bad, high is good. So those high density lipoproteins should be greater than 60. So for a safety exam, you should know antidotes. So for warfarin, it's vitamin K. For acetaminophen, it's acetylcysteine. For opioids, it's Narcan or naloxone. Aspirin, it's sodium bicarbonate. Mag sulfate, it's calcium gluconate. For heparin, it's protamine sulfate. And those are the antidotes that you should know for the Nclex. All right, so now I'm going to talk about blood administration and IV fluids administration. So with blood, before you give the administration of blood, you want to make sure that the patient is compatible with the type of blood that you ordered. So you want to make sure you know that little chart, knowing that O negative, they're the universal donor, AB positive is the universal recipient. With blood, you have to be giving that within 30 minutes of receiving blood from the blood bank, and it has to be infused within 4 hours of administration. So with blood, that's one of those medications. It is considered a medication that you administer that you need to verify with the second nurse to do your rights of medication administration, and make sure to verify this order with a second set of eyes. You want to stay with the patient for the first 15 minutes of giving the blood administration to look for if they have any reactions like anaphylactic shock. And then you also want to take a set of vitals at the 15-minute mark. If your patient does start to develop some kind of reaction to the blood, you should be stopping the infusion immediately. So with IV fluid administration, you're going to do your rites of medication administration, but there are different types of IV fluids. There's the isotonic, which means same osmolarity as blood. This is used to replace fluid losses, usually in emergencies like burns or shock. So this is going to be your normal saline, the 0.9%, or lactated ringers. Then you have hypotonic solutions. I always think of cells expanding with hypo. So that is just sucking fluid into the cells to rehydrate these cells. And the example fluid of that is going to be that half normal saline, so that 0.45%. And then finally, hypertonic solutions. These are sucking fluid out of the cells. Maybe they're in fluid overload, they got to get some of that fluid out. So that solution is going to be 3% saline. So there are different complications that can arise from IV fluid administration. You can have infiltration where fluid kind of seeps into the tissues. You're gonna discontinue whatever IV you have going. You're gonna get a warm compress because you're gonna feel the skin. It's gonna be edematous, it's gonna be cool. There's extravasation, which is you having some kind of vesicant going through that peripheral line, and it goes out into the tissues like the same thing before, but this is a vesicant where it can harm these tissues. So you're gonna see all of a sudden the skin looking so red and painful and necrosis and burning. So you're going to want to discontinue the IV, get a cold compress, and possibly give them an antidote. And then the last complication is phlebitis, which is a red streak at the insertion site. And again, you're going to want to discontinue that IV and give them a warm compress. All right, so I'm really quickly going to talk about burns. So you have different types of burns. You have superficial, which is, they might have some redness, heat, maybe some blanching of the skin. It heals quickly. Then they could have superficial partial thickness burns where they're wet, there's blisters, it's pink. They might have some pain. And then there's full partial thickness, which they're gonna have blisters. It's gonna start to get more dry. It's gonna go deeper in the skin. And it might be actually less pain because the deeper you go into the skin, the less pain they're gonna feel because it's gonna burn those nerve tissues. Next one is full thickness burns. They're gonna be waxy, they're gonna be dry, they're gonna be white, there's no pain or sensation. Something to know is that burn patients need a higher caloric intake. So something too with burns that you should probably know is the rule of nines, meaning that nines is how you're going to calculate the burn extent of the skin. All right, guys, going on to EKGs. So I made a TikTok first that I want you to watch. EKGs made ridiculously simple. So the P wave is known as atrial depolarization or contraction. After that, the blood travels down to the ventricles to form the QRS complex, known as ventricle depolarization or contraction. After that, you have the ST segment, which is the beginning of ventricular repolarization, otherwise known as relaxation. Then finally, you have the T wave, where there again is ventricular repolarization. Anything with the P wave is considered atrial, whereas the QRS is ventricular. A lack of QRS complexes means asystole. Treat it with atropine or epinephrine. This is to be aware of. Lack of QRS, asystole, sawtooth appearance, atrial flutter, chaotic, fibrillation, bizarre, tachycardia. Now that you've seen an overview, I just want to go over the rhythms real quick. So over here, this is sinus tachycardia. So you want to treat if it's symptomatic, and if it has over 100 beats per minute, that's when it's defined as that sinus tachycardia. Treatment is going to be beta blockers, calcium channel blockers, or cardioversion. There is sinus bradycardia. So the heart rate is less than 60. And again, you can do that by counting the QRS complexes and timesing that by 10. And with this, you want to treat it with atropine or even a pacemaker, and that's if it's symptomatic. Okay, so atrial flutter over here, which is kind of that sawtooth appearance. So that one you're going to treat with like the vagal maneuver or adenosine or cardioversion. So any atrial arrhythmias, whether it's flutter or afibrillation, you're going to do those ABCDs. So you're going to treat with the adenosine, you're going to treat with beta blockers, calcium channel blockers, and digoxin or lanoxone or digitalis. There's many different names. So for example, atrial flutter over here, which is like a sawtooth appearance, you're going to treat that usually with adenosine. And then AFib, you're going to use those beta blockers, the calcium channel blockers, digoxin. Some patients can even be put on warfarin. Said in that TikTok video before that tachycardia is usually described as bizarre. So if you see an issue with the QRS complex, meaning that it's ventricular, so VTAC, a bizarre QRS complex, ventricular tachycardia, this is treated with amiodarone or epi or defibrillation. So anything that has to do with the P wave is going to be considered atrial. So when you see that, do those ABCDs. Now, if it says something with the QRS, that's going to mean that it's ventricular. The most deadly one that you should be aware of, besides asystole, which is just a flat line, is going to be ventricular fibrillation. This is very deadly. A patient can be dead within 8 minutes if it's not treated properly. So you want to do CPR right away and defibrillate. And then finally, asystole. Asystole is that flat line. And just remember the A in asystole stands for atropine. E at the end of asystole is epinephrine. So those are the two things you're going to do to treat it. And only cardiovert on rhythms that have the R, the QRS complex, because you need to cardiovert on that R. So that is the time you can do that. You can do that with afibrillation. That is just one example. And then what are the ones that you can shock on? Those are like asystole, VFib, VTAC. So just a quick thing about chest tubes, what do? They reestablish negative pressure in the pleural cavity. So you have these different chambers in the chest tube. You have a water seal, a suction control, and if you notice bubbling in the water seal, this is not good. This is the sign of an air leak. So if for some reason the chest tube becomes dislodged, you need to right away put a dressing on that is tented on 3 sides. You need to monitor that patient hourly. You need to notify the provider and just keep assessing your patient. With chest tubes, it's good to also understand air pressures. So negative pressure is like keeping air inside. It's like a vacuum, keeping that inside your lungs so it stays in there. Like if a person's on airborne precautions and they are in a negative pressure room, they don't want those air particles going all over the room. They want them to stay inside their lungs. So positive pressure is where there is no air exchange. So if a patient comes in and they have like a gunshot or pneumothorax, we don't want that air to escape. We also want them to get adequate oxygenation. So it increases oxygen and decreases carbon dioxide. Get on to trach tubes. Tracheostomy is an incision made in the windpipe to relieve airway obstruction. And so the tracheostomy is that stoma that's sitting there helping these patients breathe. And so it's important when the nurse is taking care of a patient with a trach tube that you are suctioning as needed and not more than 10 seconds, okay? Because that can increase intracranial pressure, and we want to avoid doing that as much as possible. With trach tubes, you also want to use sterile technique. There's a high risk of infection, so always using sterile technique for trach tubes is incredibly important. The patient does have a trach tube. It's important at the bedside for them to have an obturator, an ambu bag, an oxygen device of some kind, suction, and a trach size that is normal to their size and one size smaller. And if they do, for some reason, have decannulation or the trach coming out, you want to call a rapid response team. You want to lay them supine, give them oxygen, and ventilate them using a bag valve mask. Okay, so now I'm going to be talking about addiction and intoxication and overdoses. So if a patient is on a depressant or a stimulant, it's actually pretty easy to remember what their withdrawal symptoms will look like or what their intoxication symptoms will look like. Because if they are on a depressant and they have too much of that, they are going to be super depressed. Everything is going to be low, right? But if they're withdrawing, it's the opposite effect. Depressant withdrawal are going to show a high heart rate, a high BP, tremors, diaphoresis. They can even have seizures. And some depressants are like alcohol, benzos, or barbiturates. Uppers, usually these are not as tested upon, but some to think about are just like caffeine, cocaine, Adderall, methamphetamines. Opioids are a little different. So we're just going to call them kind of a downer. So when you have a high amount of a downer, you're still going to be down, right? Because everything's going to go down. So your respiratory rate's down, heart rate, your blood pressure, you're going to have constricted pupils. Now, if you're withdrawing on a downer, your symptoms are going to be a little bit more high. So you're going to have panic, diaphoresis, yawning, nausea, vomiting, diarrhea, chills, and fever. So if a patient is on an opioid and they're having intoxication, remember, if their respiratory rate is 12, you want to hold whatever medication maybe that they're on and notify the provider. Less than 10, you need to intervene and give them naloxone or Narcan. All right, so this is the most important part of my lecture, in my opinion, because this is how you can answer the questions. If you know none of this information that I just taught you and it all goes out the window, I want you just to remember this section, okay? So we're gonna go over what is most important for you to answer in a question. Now, if this question that the Nclex is asking you is like, who can you discharge home? They're asking you, who is the healthiest? So you want to look at these different patients and trying to figure out who has something that's chronic, who is something that is been in the hospital for a couple days for something that's not so serious. Maybe they had a local anesthetic or, they were admitted several days ago and they're just ready to go home. That would be a patient that is okay to discharge. You know what's going to happen when they go home. Someone that is unstable. So most of these questions are kind of like this, where they're going to say, okay, which patient should the nurse look at first? Which patient should the nurse call back first? You see a lot of those kind of questions with these Nclex programs. And you're always going to look for who's the most unstable. It's like a game. Who's the most unstable? Welcome to the show. When you look for the person that that the nurse needs to intervene with first, you're going to look for somebody that has an acute issue, something that doesn't line up with their diagnosis. So maybe a patient comes in that has Crohn's, but all of a sudden they're having tremors or seizures or some kind of neurological issue going on that doesn't go with their diagnosis. So that is unstable. It's unknown. You don't know what's going to happen when they go home. Unstable would be newly diagnosed or newly admitted, or somebody that just transferred over from the ED or ICU. Those are more unstable patients that the nurse should usually tend to first. Some unexpected things that you should look at, they begin with H. Hemorrhage, high fevers of like 105 or greater, hypoglycemia, and has no pulse or breathless. Those are very unexpected. Those are your unstable patients, and if you see those, that's the first one the nurse should go to. All right, so you need to know for the Nclex delegation, know the rights of delegation, which is the right task, the right circumstance, the right person, the right communication, and the right supervision. And I always remember that with the car pedals can speed, because you don't want to fastly go through delegating and doing something wrong. You want to make sure when you are delegating to someone that you are staying in your lane and doing what is appropriate to help not only you, but to help this other person and the patient load. Okay, you want to be a safe nurse. So here's a list of things that might vary from institution to institution of what you cannot delegate to an LPN. You cannot delegate hanging or mixing IV meds, pushing IV meds, giving blood products, assessments, planning, teaching, education. You do not want to give unstable patients. And an LPN should not be the first to do anything. It usually should be the nurse who does something first, and then they can reinforce whatever was done. So if it was a wound change, they can do the second wound change. The nurse should do the first one. If they're teaching something, they should do the second set of teachings. They shouldn't do the initial. This is a list of things that you cannot delegate to a UAP. So that includes charting, giving meds, assessments, that education, that teaching, planning, treatments except enemas, and never again the first of anything. So UAPs, usually they are a really great resource for doing, ambulation, helping with meals, vitals, blood glucose. There's so many different things that LPNs and UAPs can help the nurse with. You just need to know which ones are appropriate to delegate. You do not want to give them an unstable patient or give them the first of anything, especially if they did not have that training, but you did, so that would be inappropriate. So you want to watch that on the Nclex, because you want to be a safe nurse. Love CNAs. I love LPNs too. I do. Try to convince me not to. So finally, when in doubt, when you have these test questions and you might have select all that applies, my best advice is to turn each of those little answers into a true-false statement. That'll help you eliminate any unnecessary answers. And if two answers are alike in one of those select all that apply, neither is correct. Okay? And if there's an opposite answer, so in one of these questions, one of those is usually right. Like, what is the nurse's best action? And that is not asking you what is the first thing you should do. It's asking you if you could do one thing and leave, what would it be? So when you look at your list of options, which of these things most will serve this problem or be a solution to this problem or fix it? Okay guys, I hope you enjoyed this overview. Please comment if this helped you in any way. I was super nervous to put this video out here. I almost didn't want to, but if I helped just one person, if just one of you comments that this helped you, then it will have been for something. It'll be worth it to me. So I hope you guys have a good day. I hope you pass your Nclex. You can do it. I will be rooting for you. Keep me updated. Bye, you guys.